Welcome back to part 2 with lower GI disorders. So our objectives are to name 3 non-inflammatory bowel diseases, differentiate between non-inflammatory and inflammatory bowel disease, and create a plan of care for a client with an irritable bowel disease. 2 classifications. We have non-inflammatory bowel disease and inflammatory bowel disease. Of the non-inflammatory bowel disease, we will be talking about irritable bowel syndrome and hernias. The inflammatory bowel diseases, we will be talking about ulcerative colitis, Crohn's disease. And there are other disorders including food poisoning, parasitic infections, anal disorders, which include anal rectal abscesses, anal fistulas, or anal fissures. Irritable bowel disease, or IBS, there's no clear pathological changes, and its characteristics by diarrhea, constipation, and or abdominal pain. IBS is divided into 4 categories: IBS-D, which is IBS diarrhea; IBS-C, which is irritable bowel constipation; IBS-S-A, which is both of those, and IBS-M, which is a mixture with either one of those. Again, the etiology is unclear. It's thought to be caused by a combination of environmental, immunologic, genetic, hormonal, and or stress. Assessments, we're going to watch a weight change, either a loss or unintended loss or a gain. We're going to look for fatigue, abdominal pain, and changes in bowel habits with either diarrhea or constipation and cramping associated with them. Interventions include a diary of the food to see which is bothersome and which causes the constipation or the diarrhea, including dietary fiber in bulk, and anti-diarrheal medications for the IBS-D, and some complementary and alternative therapies, which include probiotics, acupuncture, mobustation, which treats flatulence and bloating and improves stool consistency, and as well as stress management. And question number 4. The client with irritable bowel disease asks you, the nurse, what causes it? Which of the following responses would be best appropriate? This is an inflammation of the bowel caused by eating too much roughage. IBS is caused by stressful lifestyles. The cause of this condition is unknown, or there is thinning of the intestinal mucosa caused by ingestion of gluten. Hernias. We're going to talk about there's a weakness in the muscle wall, or it's a congenital defect. Indirect hernias are most common in men, and there's a large downward protrusion into the scrotal sac. Direct hernias occur most often in older adults. Femoral and umbilical hernias are most frequent in obese adults or pregnant women, and incisional occur after abdominal surgeries at the incision site. They are associated with or caused by straining or lifting. And you can tell in the picture there's the different areas of the hernias. There's further classifications of hernias, and SIR hernia is an acronym or a mnemonic that you can remember for strangulation, incarcerated, or reducible. So strangulation is when the blood supply is completely cut off, and this is an emergency situation because that bowel will die. Some signs of that are abdominal distension, nausea, vomiting, pain, fever, and tachycardia. Incarcerated means that it's entrapped outside the peritoneal cavity, which means that it's not the blood supply isn't being cut off, but it's just not able to be put back in, as in a reducible, which they can actually take their finger and kind of push it back in, and it stays in then for a while. Then interventions include non-surgical, which would be a truss or abdominal binders, usually for older adults that are not surgical candidates. And surgery can be either emergent or elective, and with the strangulation hernias, those are emergent and they have to go, otherwise that bowel will die, or elective, where they can have that as a scheduled time. Of course, we're going to take a look at our postoperative care initially with our airway and cardiac issues, as well as incisional dressing for bleeding. They can do these laparoscopic with just a few little incisions, or they can do it open where it's a bigger incision. Intestinal obstructions, the pathology, there's two classifications. One is mechanical or non-mechanical. Mechanical consists of adhesions in which scar tissue formation are from abdominal surgeries, malignancies, benign tumors, complications to appendectomies, hernias, fecal impaction, strictures developing from Crohn's disease or previous radiation therapy, intussusceptions, boluses, fibrosis, and vascular disorders. And here's a picture of the different of hernias and adhesions. The volus, which we talked about, the last upper disorders, and then the intussusception, which is a telescoping of the bowel inside each other. Characteristics of bowel obstructions: for the small bowel, it's abdominal discomfort, upper and or epigastric abdominal distension, and so you can tell that that's in the small bowel because it's higher, right? Nausea and early profuse vomiting of malodorous emesis, which would be fecal material in that vomit. Obstipation, which is severe or complete constipation. Severe fluid and electrolyte imbalances, and metabolic alkalosis. For large bowel, intermittent lower abdominal cramping. Sometimes it can be confused with IBS, because those folks will have that abdominal cramping too. Lower abdominal distension, minimal or no vomiting. Why is that? Because that's lower in the system, and so the food can move through. It doesn't back up as quickly as in small bowel. Obstipation or ribbon-like stools, where there is part of the stool is passing and so it's not completely blocked. There's no major fluid and electrolyte imbalances. Metabolic acidosis may be present. So the people with large bowel or small bowel obstructions, potential complication could be a perforation. And then you could end up with a peritonitis, which is inflammation of the peritoneal cavity. So we really have to get these people diagnosed early so we can prevent that perforation and potential complications. Here's a picture of the bowel obstruction and how and what it might look like. Okay. The bowel sounds at maybe increased to silent, and maybe high-pitched at first and then go silent. Where the distension would be, and such. So, NCLEX question number 5. You receive a patient from the emergency room department who's complained of 3-week history of constipation. The patient's abdomen is slightly distended and complains of nausea with vomiting and epigastric pain. Her lab work shows the sodium of 175, potassium of 2.0, otherwise normal. ABGs show metabolic alkalosis. What should you expect her orders to include? So NG tube placement, regular diet, chest x-ray, or Foley catheter insertion. And think about what you're going to kind of want to do and which one are we obstructed? Is it a small bowel or a large bowel? Okay, that'll help you answer the question. So inflammatory bowel disease. The first ones we're going to talk about are Crohn's disease and ulcerative colitis. Crohn's disease most often is in the terminal ileum, and it's a patchy involvement, so it's not through the whole segments of the bowel. And it affects all layers of the bowel. It's called transmural process, as opposed to ulcerative colitis, which begins in the rectum and is a continuous pattern towards the cecum. It typically involves the mucosa and the submucosa, not all layers of it. Etiology for both is unknown. Peak incidence is 15 to 40-year-olds for CD, and 15 to 25 and 55 to 65 for ulcerative colitis. Now here's the big difference. Crohn's disease, there's 5 to 6 soft loose stools a day, but they're non-bloody. But with UC, there's 10 to 20, so the frequency is much more, and they're liquid bloody stools. And remember how we talked about if they were if bright red blood, or you can tell that there's blood in the stools, that would indicate some kind of low bowel bleeding. And complications with Crohn's disease are fistulas and nutritional deficits, and ulcerative colitis is hemorrhage or nutritional deficits. Surgical intervention for Crohn's disease is frequent, and ulcerative colitis is infrequent. So here's kind of a picture of ulcerative colitis and versus Crohn's disease, and you can tell the picture of the colons how it is affected. Treatments for Crohn's disease and ulcerative colitis, there's non-surgical, which includes drug therapy, and I've got listed the different kinds of medicines, the categories that would be used for each one. And the main difference is the Crohn's disease, there's monoclonal antibiotics that can be used to help with that. You've seen the commercials on the television about Crohn's disease and the different medications that they have out. And nutritional therapy, we want to have bowel rest for both of them with acute phases. With UC, you want to decrease activity. A possible TPN, UC, you want to avoid alcohol and caffeine, raw vegetables or high fiber foods, and lactose, which sometimes makes it worse. And with CD, remember how they have long-term nutritional deficits. CD also has complication of fistulas that would increase the need for calories and different nutritional needs there because it would cause muscle breakdown, and so you want to watch that. And surgical management for ulcerative colitis, there's restorative proctocolectomy with ileopouch anal anastomosis, and ileostomy, which could be a permanent or a temporary ileostomy. And that's just like a colostomy. It's an ostomy is an artificial opening to where the bowel is eliminated. And the ileostomy is in the ileum, is the location of it. And CD, the surgery is due to complications of the disease, and stricturoplasty, where they were removing that stricture that could be causing that Crohn's disease, or caused by that Crohn's disease. NCLEX question number 6. A client with Crohn's disease who's taking sulfasalazine asked the nurse why the medication is necessary. Which information should the nurse include in her response? And those are listed there. And our assignment, I'm giving you till Thursday at 11 p.m. to pick a lower, upper, or upper GI disease and describe a life in the day of that patient. But pick one and don't duplicate, please. Describe what the day would look like, how the patient might feel, special diets, and then by Saturday, 11:59, respond to one of your peers on any new insights or any ideas that you've gleaned from that and how the patient may feel. Thanks for listening, and I look forward to your posts. Have a nice day.